Thank you for coming to our Psychiatry Grand Rounds. I am here to introduce one of my fellow co-residents here, Dr. David Jensen. He is one of our third years. So he received his Bachelor of Arts in French Language at Wright State University, summa cum laude. He received his Doctor of Osteopathic Medicine at Lincoln Memorial University, DeBusk College of Osteopathic Medicine. And then he came here, obviously, for ETSU as he's in his third year today, presenting to us all about the placebo effect. So, warm welcome and applause for Dr. Jensen.
All right. So first off, thanks everybody for coming to Grand Rounds today. Before we get started, I wanted to talk a little bit about how I came to the decision to talk about this topic for Grand Rounds. And so through medical education, whenever I was exposed to different research studies on different medications, I was always impressed by how similar the placebo response curve and the medication response curves were to each other, and the idea that in most of those studies, the majority of the improvement that was seen in all of the patients or the research subjects had to be from something else other than which medicine was selected. And I know that's which medicine that we select is often kind of the primary consideration that's given when in a clinical situation you've got a patient complaining of some kind of syndrome and you're trying to help them. But in reality, it's a lot more complicated than that. There's a lot more that goes into somebody's healing, and that's what I wanted to learn more about. So today I'm hoping to share with you kind of what I found. And so if anybody is cringing when they're looking at the title, I do know how to spell effect, but this is supposed to be a little bit punny, that because this is the placebo effect in psychiatry, I titled it the placebo affect. So let's go ahead and get started. Before we really get into it, though, can somebody tell me what a placebo is? Or just raise your hand, shout it out, whatever. What? It's a fake? Okay. What else?
No active ingredient.
Yeah, right, exactly. So it's some intervention that is thought not to have an active ingredient in it, but that still results in the perception that somebody is being treated, right? So here's my disclaimer. I don't have any kind of financial conflict of interest to report. So the objectives for today's discussion: first, understand the role of the placebo in clinical trials and in medical research. Identify several factors that contribute to the placebo effect. Review some biological mechanisms underlying the conditioning to a placebo. Appreciate that non-pharmacological factors often account for the majority of a treatment effect. Identify some conditions that have characteristically large placebo response rates, such as mild depression, fatigue, pain, insomnia, and mild anxiety, and those that have more limited placebo response rates, such as psychosis, severe depression, or OCD. Be able to employ these other factors in clinical practice to promote maximal healing. I would like to take a kind of a poll from the audience, because there are a lot of faces that I don't recognize here. How many people here are involved in any kind of clinical treatment of patients in any capacity or who plan to be in the future? Is that most everybody? Okay. So then whether you're in psychology or psychiatry or medicine or a medical student, then this should apply to most of your patient encounters. So I always like to know where things began and where the origins of them are. So placebo is actually Latin, and placebo means I shall please. Its first most widespread use was in the Office of the Dead, which is a prayer service for the deceased that was used throughout Christian medieval Europe. When somebody died at their funeral service, it would start out with these words, Placebo Domino in regione vivorum, which means I shall please the Lord in the region of the living. For me, this gives kind of a context for how the placebo is used in medicine and in research, in that it's being used to please the patient and to ease their mind more so than its active ingredient. So here's a little bit of history about how the placebo came to be in medicine and in psychiatry specifically. So in 1938, we had the first placebo-controlled study in psychiatry. It was a benzodrine, which is racemic amphetamine. It's a stimulant that was thought to improve depression. And this was a crossover study in 48 female inpatients with depression. And they found that during the active treatment phase, the patients had significantly fewer depressive symptoms and much less severity of their depression than when they were treated with the placebo. From 1947 to 1951 is when we get a lot more literature using the placebo in randomization, and this was in the wake of tuberculosis drug studies. And then in 1952, we've got a famous psychiatric study that used placebo compared to lithium in the treatment of mania. And to date, lithium is still the gold standard for treatment of bipolar disorder. So what different factors go into a person's treatment response, whether they're given placebo or any intervention medication? So there's always a patient who is suffering, or a research participant who is suffering from some chief complaint. Then there's a recognized healer, which is the provider, the clinician, the physician, what have you. Then the two of them have to form a relationship. Then there has to be an evaluation of the patient's complaint by that recognized healer or provider. Then there's a diagnosis that is made and is discussed about. Then there is a prognosis or an expectation for improvement that is discussed and appreciated. And then we have a treatment that is decided upon. Then there is time before the response is evaluated. And so in most clinical studies, what we're looking at are these last three that are in this orange color here. We're looking at the treatment, which is the placebo or the medication or the active therapy. And then there's usually a certain number of weeks to months before the outcome is measured. So before we go any further, I'd like to discuss some terms. Placebo response and placebo effect are a little bit different. The placebo response is the change in the placebo arm from all factors. The placebo effect is the difference in the placebo arm versus whatever the control group is that is supposed to represent no treatment. And so you can think of the placebo effect as the specific effect from the inactive placebo treatment. And then nocebo is the notion that a placebo can also cause harm, not just benefit, right? So if somebody is given a placebo or like a sugar pill, for example, and then they develop a side effect like nausea, the nausea would be a nocebo effect of what should be the placebo, okay? So here's an example from a trial that was comparing placebo response with low-dose versus high-dose SSRI therapy. The specific medications that were compared were citalopram, sertraline, and paroxetine. And the metric that they used in this 6-week study was the Hamilton Depression Rating Scale. Now this is a self-administered rating scale. The maximum score is 52. Under 7 is generally representative of remission of all depressive symptoms, and then above 20 is generally associated with moderate severity. And so in this study, what we see is that the placebo response curve that is shown in red here is closer to both of the medication therapies than it is to no change at all, right? And it looks like the placebo response here is about 9 points of reduction on the Hamilton Depression Rating Scale, and that the highest dose SSRI therapy is 12 points of reduction on that same scale, such that the placebo response here is accounting for about 75% of the treatment effect that is seen with the active medication treatment. And so just to kind of visualize that, that's a big chunk. And so the placebo here is pretty effective. And this is shown throughout most psychiatric studies. You're looking at about a 3/4 as the placebo response, or 75% compared with the active treatment. So this is not at all an uncommon finding. Here's another way to kind of visualize it. In any given sample or condition, especially one that tends to fluctuate in severity over time, as many conditions within psychiatry do, a certain amount of people will spontaneously improve without any treatment or intervention. And that's estimated to be about 1/4 of patients. Then, if given placebo, an additional portion of the people will find improvement. You're looking at about 50% from the placebo effect, which here's just the red strip. The placebo response, just for clarification, would be from the center of the circle all the way out to the edge. And then you've got the active treatment effect, which accounts for another about 25%. So there are some limitations when studying the placebo effect itself. Like we had alluded to, there's spontaneous remission. Think of substance use disorders, of episodic mood conditions like bipolar disorder or depression, where it's expected that these conditions without any intervention will fluctuate in their severity over time. In no treatment control groups for mild depression, the no treatment effect is actually quite strong at up to 81%. The way that we try to control and represent no treatment in many drug studies is with either a waitlist control or a treatment as usual arm. And in either of these two treatments, the waitlist control, the idea there is that the subjects that are assigned to that treatment will eventually get into the active treatment trial. Treatment as usual, if framed as treatment as usual, could instill a sense of hope in the patient because they're getting the next best treatment, or depending on the patient's attitude, they could also respond to that with a negative outlook. That person could think that their treatment is inferior to the active treatment study. They might be disappointed that they aren't actively being, that they weren't allowed to be a participant in the actual study. And so depending on the patient's attitude, you could have a placebo effect or a nocebo effect from even the no treatment control group. And oftentimes in studies, we don't see the attitudes of the patients assigned to the no treatment control group identified. That's usually not something that's asked about, and yet it could have a pretty strong effect. So that to say, when reading literature, no treatment does not necessarily mean no treatment. There are still some attitudes and psychological changes that are implicated in that. Here's a study comparing different conditions and the relative sizes of the active treatment, the placebo, and no treatment. And what I'd like to point out here is that the stronger placebo responses we can see in phobia and in nausea. And the no treatment responses are pretty high in depression and nausea and smoking. And that certainly does suggest that those conditions are likely to improve on their own without any treatment. Something that did stick out to me is that for insomnia, no treatment was actually harmful, and in acute pain, placebo was actually harmful. And I don't have really anything else to point out. I just thought that was interesting for those. So there are ethical considerations as well whenever the placebo effect itself is studied. In 1964, there was a document that was adopted by the World Medical Association, and it's called the Declaration of Helsinki, and it outlines ethical principles for the research of human subjects in medicine. And this came about 20 years after World War II, and I think a lot of us know from history class that in World War II there were a lot of questionable ethical medical experiments going on in Nazi Germany. Also in the earlier 20th century, in the 1930s, I think of the Tuskegee syphilis study, where they subjected African Americans to no treatment just to see what the natural course of syphilis would be, even though at that time we did have penicillin, and that was shown to be beneficial. So the medical community as a whole, I think, is probably in the 60s. It took about that long to really catch on in for the world's scientific research community to really care about the ethics of studying interventions in medicine. So here's an excerpt from the Declaration of Helsinki. And the two things I'd like to point out on here, at the top, the best proven intervention, we can also call that treatment as usual. I think that's usually how it's represented in scientific literature. That is the control that is established as ethical. Placebo is not the best proven intervention because it is by nature inactive, right? And so this limits the ethics of studying the placebo effect. And then here at the bottom, it says that patients who receive any intervention less effective than the best proven one, or a placebo or no intervention, will not be subject to additional risks of serious or irreversible harm as a result of not receiving the best proven intervention. So can anybody think of a condition in psychiatry where no treatment would be harmful? Mm-hmm. Schizophrenia. What could happen if schizophrenia goes untreated? Yeah, it could get much worse. And we know that in schizophrenia, there's a higher risk of suicide, right? Severe depression, there's also a high risk of suicide. Bipolar disorder, high risk of suicide. So in many of the conditions in psychiatry, the idea of not providing the best available treatment option could be fatal. And what we see after the adoption of the Declaration of Helsinki here, if you look here, the number, so this is the publication year and the number of placebo trials actually looking at the placebo effect itself. And here in 1964 is when the Declaration of Helsinki was adopted. And then we see a decline in the placebo studies after that point for several years. And it takes until the 80s or 90s before that starts to pick up again. And I'm not sure exactly what prompted the interest in the 90s, but I thought it was interesting that the adoption of the Declaration of Helsinki seemed to coincide with a significant decline in actually studying the placebo effect. So some mechanisms of change. So what actually goes into a patient healing from a placebo? Now that we have more advanced imaging technologies in the last couple of decades, we're able to actually look at functional MRI and PET scan comparisons of patients who take placebo versus active medicine versus no treatment. And what we found is that the changes that are seen in different brain regions mimic almost perfectly the specific structural changes of whatever the active treatment happens to be. One of the pathways that is common to nearly all placebo effects is the dopaminergic transmission, specifically in the nucleus accumbens, the brainstem, and the prefrontal cortex. So I've got a photo here. Well, it's not a photo. It's an illustration, I guess. But the nucleus accumbens here is this circle in the center. And the prefrontal cortex is on the right side, and I've represented it by a brain and a heart, and that's because the dorsolateral prefrontal cortex is involved in the cognitive evaluation of reward and benefit and motivation, whereas the ventromedial prefrontal cortex, represented by the heart, is responsible for the affective or the emotional regulation associated with the evaluation of reward or expectation. And then last, we've got these brainstem regions. Here's the ventral tegmental area. That's where that lives. So another word about the dorsolateral prefrontal cortex. This structure is responsible for mediating motivation to obtain a reward. Again, this is the cognitive center that mediates this. So it then communicates to the ventral tegmental area and the nucleus accumbens to drive action and the sense of reward. So whenever taking a medication, there needs to be a motivation prompting that. There needs to be some kind of expectation, otherwise, why are you taking the medicine? What is that doing, right? And so we can think about this as the expectation of improvement or as hope. So kind of by extension, you can think of hope as residing in the dorsolateral prefrontal cortex. A word about the frontal cortex. If it's true that the prefrontal cortex is necessary in order to establish a sense of expectation and hope, then it would follow that the placebo effect could potentially be mediated by the frontal lobe first, such that if the frontal lobe were knocked out or dysfunctional, then that would halt the placebo response from occurring at the beginning. So this was actually studied, and they used Alzheimer's disease as a model of degeneration of the frontal lobe over time. Now in Alzheimer's disease, you get degeneration of the temporal lobes, of the frontal lobe, and eventually of all different brain regions, right? But with a test known as the Frontal Assessment Battery, they were able to look independently at the frontal lobe functioning in the patients with the dementia and to see if that was correlated with the placebo effect. And so for this study, they used analgesia as the active treatment and then also as the placebo. And I don't know exactly what they used as the placebo, if it was sugar, or if it was saline, or if it was oral. I'm not clear. But the point of this study is that the frontal lobe functioning was independently associated with the size of the placebo effect, such that in the patients who did not have as good frontal lobe functioning, they did not respond as well to the placebo effect. So we can look at glucose uptake in different regions of the brain using FDG or fluorodeoxyglucose PET imaging. And this study in particular that I'm about to share is of inpatient men in a placebo-controlled randomized study of fluoxetine. They did these FDG PET scans at initiation, at 1 week, and at 6 weeks. And some patterns that they noticed at the 6-week or the end of the study. In those who responded to the therapy, there were increases in the prefrontal, parietal, and posterior cingulate. There were decreases in the glucose uptake in the subgenual cingulate. And so an increase here means that it's more metabolically active, and a decrease means that it's less metabolically active. And then in the active drug, but not in the placebo, there were increases in the pons and decreases in the caudate, insula, and hippocampus. So let's look at where these are kind of visually. So on the top here you have active fluoxetine. In the center you've got placebo fluoxetine, and at the bottom you've got cognitive therapy. And the cool thing about this study is that they've got the cognitive therapy control. The idea that they were trying to test with this study is whether cognitive therapy, which was also a proven and effective treatment for depression, is responsible if maybe the common factors in the therapy were responsible for mediating the placebo effect or not. And as you can see, there's a complete difference in placebo fluoxetine versus cognitive therapy, which suggests that it's not therapy that the placebo responders are responding to. It's the actual placebo itself. There's something about them taking the pill with the expectation of improvement that is actually leading to their getting better. And the placebo fluoxetine group here, compared with the active fluoxetine, is very, very similar. In the anterior cingulate, in the posterior cingulate, and in the prefrontal cortex here. Okay? So what about different study characteristics or trial designs can mediate the placebo response? So again, recall this circle with the spontaneous improvement placebo effect in just active treatment. And then this is another schematic representation of essentially the same thing. And first off, we're going to talk about this left side here. Well, we've already discussed spontaneous remission and how with no treatment some people will get better. I'd like next to discuss cognitive biases, and then we'll get to regression to the mean, which is a statistical concept. For cognitive biases, does anybody know what a cognitive bias is? Can anybody give me just a quick description? Yeah, it's a distortion in thinking that is caused by one's own understanding of how the world works based on prior interactions that they've had with different things, right? And so everybody operates with cognitive biases, and they can be very powerful things, especially in the practice of medicine. In this study that I took this chart from, they found that cognitive biases were responsible in affecting the outcome of a diagnosis or management in a medical clinical situation in 37 to 77% of cases. So at least a third, but potentially up to 3/4. So that's a lot. And I did not look to find other studies that confirm that same number, but I was impressed by this one because that's a significant alteration in the treatment or the diagnostic conclusions based on cognitive biases. So some examples of cognitive biases, we have anchoring first, which is depending too much on initial information. So if you, at the beginning of your diagnostic workup, you come to a conclusion that this person seems like they're schizophrenic, then you might ignore other data that comes in that suggests that they might have an alternative diagnosis in favor of your initial conclusion. So that's an example of anchoring. Availability bias is an overestimation of the probability of an event based upon particularly memorable experiences. So for example, say you had a really bad patient outcome when you used a particular medicine. You might be less inclined to use that medicine the next time. That would be an example of availability bias. Confirmation bias is when we reject the data that doesn't confirm our pre-held conclusions. And then framing. An example of this is if you're calling a treatment no treatment, that inherently sounds like it's inferior. And so then you're framing it as something that's inferior. So the wording that is used in research designs can be very powerful in affecting the cognitive biases of the people assigned to that group. Omission bias is the preference to fail to change rather than to change too readily, such that people are more likely to be conservative in their conclusions and their beliefs and are more resistant to changing those beliefs. And then overconfidence is pretty self-explanatory. All right, and then next we're going to talk about regression to the mean and what that means. So it's a statistical concept, and essentially it's the tendency for things to become more average. And this is one of the mediators of the placebo effect, or of the no treatment effect as well. In a clinical trial, the group that is studied is often less average because of the inclusion criteria that are applied to them in order to get them into the study. In other words, they're more pathological than the general population. So if you're studying like severe depression, for example, those patients are more severe than the general population. So even without any treatment, if you randomly selected those patients a few months down the road, independent of spontaneous remission, those patients will look better because they will tend to become more like the average population. Here's an example. Assume 100 students take a test, 10 of them fail. Those failings are probably a combination of either poor skill or bad luck. If you retest those same students, they will probably do better because you're taking those particular students who are in the bottom and you're retesting them. The students who had bad luck the first time might not have bad luck again. And the ones with poor skill the first time might actually have good luck on the retest. So they end up being more average just because you're testing them again. And then you can also think of it the opposite way. If you retested the top scorers, those test scores are not going to be as high as they were initially. So here's a medical clinical example. So for Alzheimer's disease, in assessing behavioral disturbances, such as agitation, there are often very little difference in placebo versus medication versus therapy. And by nature of the study design, you're going to select those who are more severe with Alzheimer's disease, those who are more severely affected. Just by retesting those same patients later on, they're more likely to be more like the average Alzheimer's patient than they are like the behaviorally disturbed patient. And so you get a lot of confounding by this statistical principle of regression to the mean. All right. Also a note about uneven randomization. The ideal randomization ratio is 1-to-1 for active treatment versus placebo. As this ratio becomes greater, or as more study participants are assigned to the active treatment group, the placebo effect actually becomes stronger. In other words, in any given study, the more people who receive an active treatment, the more everybody in the study improves. And it's not sure what the mechanism of this is, but perhaps it's a group-based expectation. If you're around other people who are feeling better, you might feel better yourself. But that's just my suggestion. I don't have any data to support that. Also, a word about expectation and conditioning. So the expectation can be a very powerful thing, and the placebo effect is seen earlier in the course of treatment, whereas the active medication effects are often seen a little bit later on. Longer studies of placebo and active medication show a lack of placebo to sustain remission, whereas the active medication, that's when you start to get the split off from the medicine versus the placebo. An example of conditioning here and expectation is that if you give people who have had benefit with aspirin for their headaches a placebo that looks like aspirin, their headaches will respond to that. And then also placebos are more effective when they follow active drugs than if they're given on their own, because you're already expecting the response that you've gotten from the active drug. Going back to some of the brain imaging studies, week 1 is earlier in the course of treatment than you would expect to see a medication work. Usually most of the studies that we see on depression, the medication effects start to be most prominent at like 4 to 8 weeks or so. So week 1 is well before the general accepted effect of medications. And so we can use week 1 to determine what the expectation is in a certain subset of patients. And what we find is in these two brain regions, the ventral striatum and the orbitofrontal cortex, you get a lot of activity at week 1 that disappears by week 6 and is not seen in the drug responders. So this kind of confirms what we were saying earlier about the dorsolateral prefrontal cortex and its role in expectation and improvement. As you see, these regions are not active in the people who did not respond to the medicine. In the people who did respond versus the people who responded to placebo, at week 1, these two regions are both more active in their glucose metabolism, and that does disappear by week 6. This experiment is pretty interesting to me. You can actually condition immunosuppression. That's something that I did not know. So in 1975, they took a group of rats, and they gave some of them cyclophosphamide, which is an immunosuppressant, along with saccharin, which is a type of sugar. Then they immunized the rats with sheep red blood cells, and they found that those who were conditioned with the saccharin, if they were given saccharin without the immunosuppressant, they actually had lower levels of the antibody against the red blood cells than the rats who were not conditioned and who were given saccharin, such that the conditioning with saccharin was shown to be immunosuppressive. And sugar, by nature, should not be immunosuppressive. So this is a pretty cool finding. And it does translate to humans as well. There was a study of healthy male volunteers in which they paired cyclosporin A, which is another immunosuppressive drug, with a flavored drink. And then they found that when the flavored drink was given to those specific study participants later on without the immunosuppressant, those participants had a suppression of their IL-2 and interferon gamma mRNA expression compared to the other group. And then also going with the expectation, when studying analgesia, if you give Toradol for 2 days as preconditioning, and then you suggest that the placebo is also going to be analgesic, then that becomes true. If you suggest that it's going to have the opposite effect or cause more pain because it's different than what they had been giving, then that also is true. Those patients will respond with more pain. And in this study, the expectation that was suggested by the researchers entirely mediated the effect of whether they had more pain or less pain. So next, we're going to talk about different patient characteristics that might make people more susceptible to a placebo response or not. So some factors that are probably not mediating placebo effect size are age, sex, the trial duration, and patient personality traits. Several decades ago, it was thought that certain personality traits like suggestibility would show a higher placebo effect size, but then that has been found in several studies not to be the case anymore. So that's probably not mediating the placebo effect that we're seeing in drug trials. What is probably influential, when children are included in research studies, it matters what the parental attitude is as to what the size of the placebo effect is in those children. Race in ADHD and anxiety in 2 studies was shown to be correlated with the size of the placebo effect. However, I did not see in that study where they controlled for the parental attitudes. And as we know, culture informs attitudes pretty strongly. And so that maybe race is, maybe race isn't. I don't know that we know that yet. Low symptom severity is associated with an increase in the placebo effect size, as is the short duration of illness, also associated with the placebo effect size. And that kind of makes sense. If your symptoms aren't severe, then you can probably, they're less likely to continue, right? They're more likely to spontaneously remit, and they might be more suggestible. Something else that I found is in patients who have had prior antidepressant treatment, placebo is different than active drug. In patients who have not had any prior exposure to antidepressants, who are antidepressant naive, there is no difference between placebo effect size and the active treatment size. And if this is true, and I've got 2 studies here that showed that, and we'll talk about those, but if this is true, then that suggests that giving an antidepressant naive patient an active medication really doesn't do anything. Alternatively, it could also suggest that once you're given an antidepressant, then you're more likely to become dependent upon that antidepressant for remission of your symptoms. And if that antidepressant is ever stopped, you're much more likely to relapse. So those are, this could, if this is true and it's shown in several studies, this might profoundly impact the way that we prescribe, especially to people who have never taken medications before for their condition. So in this 2015 study on the right, let me tell you a little bit about this study. It was an 8-week study that looked at antidepressant medication. They used venlafaxine, duloxetine, or escitalopram, all antidepressants. And those who had a prior exposure to antidepressants are on the left here. Those without prior exposure are on the right. And then the study on the left was an 8-week randomized double-blind treatment of fluoxetine or venlafaxine compared to placebo. And in that one, they also had the same conclusion. Also do note that the author is the same for both of these studies. And given our discussion of cognitive biases and study design, that probably also plays in. So take this with a grain of salt, but do know that this could, if it's replicated, be pretty profoundly impactful. So non-drug therapy. So let's talk about the problem of blinding. So in non-drug therapy, it's very difficult to blind. Consider psychotherapy, where the therapist performing the treatment has to know what they're doing. You cannot have a double-blinded psychotherapy trial. That doesn't make any sense. Also with acupuncture, the practitioner has to know where they're placing the needles. At best, that can be single-blinded. It's not going to be double-blinded. Light therapy probably can't even be single-blinded because you know if you're getting the light therapy or not. You know if you're being exposed to bright light or not. And then things like TMS or ECT can have profound effects that the patients themselves can feel. So if those patients have had those interventions in the past, it's very difficult to blind them to that. So some significant limitations with non-drug therapy. Also, a note about empathy. So when they've studied sham acupuncture versus real acupuncture, they found that just by having a 20-minute intensive discussion with the patients, that doubled the placebo response. And so that is a very powerful effect size for empathy. So don't sell that short in your interactions with patients. Make sure that you're taking time with them, because that can, as we see here, that can double the response. I'd like to also talk about the notion of common factors in psychotherapy. So for several decades now, there's been a question of how much of psychotherapy treatment is specific to the individual modality that you're using, whether it's cognitive behavioral therapy or psychodynamic or supportive therapy, versus common factors that are present in all therapies. And what they found is that the qualities in this list here are all associated with a better response independent of the specific type of therapy. And as you look at this list, we can see that a lot of these factors are also present in a provider-patient relationship in the prescription of medications, right? So things like, on the left side, the therapeutic alliance, the therapist's expertise, the active participation of both. Those things should be present in a trusting doctor-patient, provider-patient scenario, and they should be applicable to drug trials of placebo and active medication, such that these are probably mediating some of the placebo effect. Also, going back to the issue of blinding, it's often not as successful as we assume. So just because the title or the abstract of a study says that it's double-blinded doesn't mean that it's truly double-blinded. Here's a 1986 study of imipramine, phenelzine, or placebo. And what they showed here is that the doctors on the right side and the patients on the left side, everybody was better than chance at guessing what arm they were prescribed to. The doctors were very good at that, and the patients, when they were given the active drug, were very good at that. Here's another study where now they split it out into non-responders versus responders, and they assess the same thing. And so some of these things make sense, right? In responders, given the active drug, you're going to see probably those people are going to guess that they're in the active drug trial, so they're probably going to correctly identify that. So those two orange bars on the left make sense. Some things that did not make so much sense, and I was a little more surprised about, are that doctors and patients on the right side in those orange bars were able to correctly guess that even if the patient did not respond, that they were given the active drug rather than the placebo. And maybe that's because of side effects that they experienced that tipped them off that they were taking the active drug rather than the placebo. I guess we don't exactly know that, but that would make sense. But again, the takeaway is that more than chance would be 50%, right? More than chance, everybody, all the arms, were able to have some inkling about what they were given in this study that was supposedly double-blinded. And we also know that breaking blind, which means determining what, being able to tell what arm you were assigned to, does affect the trial outcome. So in 2013, there was a meta-analysis of 47 different placebo-controlled trials that specifically assessed blinding. And they found that there's a 0.5 correlation between correctly assessing the therapy and the size of or the difference in placebo and active treatment. In other words, the less effective the blinding, the greater the placebo drug difference. here's an illustration that might make this a little easier. So on the right side, you have a patient taking an active treatment. On the left side, that patient is assigned to the placebo. If the blinding is ineffective and they can tell what group they're assigned to, the one taking the active treatment is more likely to respond. The one taking the inactive treatment is less likely to respond. And so I'll just be aware that just because something says it's double-blinded doesn't really mean that it is. And so we always have to be skeptical when we're looking at studies. So here to kind of wrap up, although placebo isn't actively prescribed, its effects mediate much of the clinical response, and as we see in many cases, most of the clinical response. These following things matter. It matters if the provider is empathetic. It matters what the expectation is of the patient, whether they are experiencing a sense of hope and trust in the provider or the treatment. It matters what the natural course of the illness is and the likelihood of spontaneous remission, what prior treatment that patient has had and any response history, and it matters any conditioning that they have had in the past. So all these things are present in all of our patient encounters, and basically my point is that they shouldn't be ignored. We should pay attention to these things because they can have a powerful impact. And by appreciating them, we can maximize healing. So back to the objectives. Hopefully today I've been able to explain the role of placebo in clinical trials, several of the factors that contribute to the placebo effect, and really the difference between placebo effect and placebo response. Some of the biological mechanisms that underlie the conditioning to a placebo. Share an appreciation that non-pharmacological factors often account for a majority of the treatment effect, identify the relative placebo response rates in various conditions, and really just be able to employ this information. So thank you for your attention. Does anybody have any questions, comments?
I'm not going to wait for you to bring that up. I think I'm loud enough. I'm sorry, I have to rush for a meeting. So I had a couple of, comments/questions. So, there are studies where they do a placebo washout kind of time frame and then put into active versus another round of placebo. So that would be something that would count for some of the early response you're talking about as well. So that makes it a lot more expense in a longer period of time. It's harder to retain patients for that long period of time. But that might be better study to look at true drug placebo differences. The other question I had was, you talked about, we think about sugar, we talk about it generically, there's version of sugar, and which is inert, relatively speaking, I guess, to some degree. But I'm just wondering, there's such an association we have, not everybody, maybe, but maybe many of us, the sugar somehow is a reward, it's a positive, it's a dessert, I'm just curious, is there any thoughts around that from a scientific standpoint as to whether that's active in a way? And is it creating any endogenous responses that actually might mediate?
That's very interesting, and I've never personally taken a placebo, so I don't know if it actually tastes sweet or if it's like coated, or I guess it would depend on exactly what's used. But that's interesting, yeah. Yeah.
With the rats and things.
Right. And in that case, it's the conditioning that accounted for that because it was sweet. The rats could taste the sweetness, and they associated the sweetness, and their immune system associated the sweetness with the immunosuppression.
And then the other thing is the regression to the mean that you talked about. So then the studies that have been done in real-world populations versus the pure populations that have all these exclusions, where they exclude women and all of that. So realistically, even though in some ways that is a dirty population as far as you can't exclude it out, also makes sense because you're saying that they're not as different in terms of the two population studies. So it might make more sense and those be more valid results to look at because you're actually dealing with the real conditions.
Right. Yeah, that's a good point. Any other comments? Yeah.
Are you aware of a medication called SIBO caps?
Oh, is that just like an inversion of the word placebo?
So in
But Yeah.
they were actually prescribing placebo, 3 different types of different capsules.
Yeah.
And there was nothing in them more than lactulose. So early 2000s, we were actually prescribing placebos. Do you think we should continue doing that or bring that back?
So,
Recently, but
yeah, so that's interesting, and that does bring up an ethical dilemma, doesn't it? And it depends on exactly how it's phrased to the patient, whether they know that it's just a pill of lactulose or whether you're deceiving them in some way. And I think commonly in medical ethics, the idea is that that's not okay to deceive patients. So if you're doing that with that frame, then probably that's not good. But if the patient knows that they're taking a placebo and they are aware of the placebo effect and they're trying to use that intentionally to get a conditioned effect, or they think that there's something behaviorally about actually taking a pill that they want to associate with the hope for improvement, then what you have is an awareness of almost like a meditative impact of the placebo. So then I don't see anything ethically wrong with that. But yeah, that's very interesting. Mm-hmm.
Between the two groups, the individual differences in the placebo group, like say there's people in a group who are relatively identical, and yet one responds better to the placebo, or say there's like say 20 people in the group and say like half respond. Say like the placebo group responds overall like a certain direction, but there's like 10 individuals in the group that respond better than the other 10. Are there explanations for that?
Yeah, if we go, so that's kind of the patient characteristics. Let me see if I can find that again. These ones on the right side that might be influential, it could be that those patients have a lower symptom severity or have had the illness for a shorter duration. But then also, as we see with the attitudes with parents for children, I'm sure that that's probably true for the patients themselves, what attitude they had towards the treatment and how much hope they placed in it. But other than that, I don't have any other answers. But yeah.
Any other questions? Well, let's give Dr. Jensen a round of applause.
Yeah. Well, thank you.